Great. Perfect. So first of all, I'd like to welcome everyone to the course. I have a few things I need to read at the beginning of the course per the AUA. The AUA 2026 Annual Meeting mobile app is available and is free to download. When you download the app, you'll be asked for a username and password. We'd like to thank our supporters for these educational series: Astellas, Lantheus Medical Imaging, Novartis, and Pfizer. Course materials are available on the AUA website and the mobile app. Use the email you used to register. Your password is your AUA ID. You can find it on your registration badge. As part of the disclosure policy, the AUA determines whether disclosed relationships with ACCME-defined ineligible companies are relevant to the educational content of the CME session and mitigates any conflicts of interest prior to the session. The full disclosure policy and report of relevant financial relationships are posted on the AUA's annual meeting website. Address is given, and a link is posted on the mobile app. CMA credit claim. Please ensure that you log into the CME credit claim site and confirm the session has been added to your record. The link is posted in the mobile app and through the QR codes in the meeting guide and signage. Please follow the instructions on the site to ensure you complete the entire credit claim process for all sessions as soon as possible, but no later than December 31st. No credit will be given after this date. Please remember to silence your cell phones. There are no photos, video, or audio recordings permitted during the session. So first, I'd like to take the time to welcome everyone. I'm Pepe Wagner, Joseph Wagner, director of this course. And we know you have a lot of choices to make during the AUA meeting. We're very pleased you chose to spend your time this afternoon with us. I'd also like to introduce Matt Cooperberg, UCSF. These are his disclosures. Peter Pinto will be here in just a bit from the National Cancer Institute. These are his disclosures. And Dan Lin also contributed to the content of this. I'd like to take the opportunity to congratulate him this weekend because his son is graduating from college, but he won't be doing his lectures this year. Matt and I will take those over. His disclosures. So our learning objectives today are to describe the seminal validation studies for prostate cancer for genomic and artificial intelligence testing, list the different prognostic endpoints provided by these various tests, we'll identify the appropriate test to use based on a patient's unique clinical characteristics, we'll review the NCCN guidelines for these tests, and advanced imaging for prostate cancer, what and when will be covered by Peter. I'll be covering the overview and background. Matt's going to talk to you about pre-diagnostic markers. Peter will speak about advanced imaging. Back to Matt for germline testing and genomic testing and artificial intelligence at diagnosis. I'll handle genomic testing and artificial intelligence after prostate cancer treatment, and then we'll leave some time at the end for some questions and some panel discussions. So overview and background, it's going back to college biology. But germinal tissue are inherited mutations. They're present in the germ tissue, and some of your progeny may inherit those mutations, some may not. Somatic mutations are acquired mutations. So germline mutations, again, inherited from either parent, present in each cell. And genomic tests are examining somatic mutations in the tumor itself. This has gotten very, very messy, right? Not all tests that we sort of call genomic tests are truly genomic tests. Some are not examining mutations. Confirm MDX, for instance, is looking at hypermethylation. ExoDX, which is a urine test, is looking at extravesical RNA, and there are various protein tests available. So, we all throw this term artificial intelligence around, I think, very loosely nowadays, but really, artificial intelligence is a theory and development of computer systems to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision-making, and translation between languages. And it really came about in the 1950s, evolved to machine learning in the 1980s, and now we have generative AI, and I'm sure everyone's playing on ChatGPT and Cloud and every other tool that's out there, and it's pretty amazing what this stuff can do, and I think we're all sort of figuring out how to appropriately use it. So prostate cancer at diagnosis, a lot of decisions. Matt's going to go over all of these in his talk on diagnosis. And then a little bit of a flashback to biochemistry. So just to remind everyone, you have DNA in your cells. DNA is transcribed to RNA, and then RNA is translated into proteins. Those are the really, action points of the whole process. And there are various tests at each stage. So IMPACT is a Memorial Sloan Kettering proprietary next generation sequencing of DNA. Various RNA tests we're going to talk about today, Decipher, GPS, et cetera. And then protein tests such as P10. So why do we need genomic testing? And again, when I say genomic testing, try to just lump all these things together in your mind. It's artificial intelligence, it's true mutational analysis, it might be a protein test. Well, we know that the traditional parameters of PSA, clinical stage, pathology, tumor volume, PSA density, all the things that go into our sort of mental algorithm of how we're going to treat a patient aren't accurate. And we try to combine those things into tools such as CAPRA tables, Parton tables, nomograms, NCCN guidelines, et cetera, but they're far from telling us the accurate, true picture. And I have one study here from European Urology from a few years ago. They took 10,000 patients that had favorable intermediate risk disease, and around 30% of the patients were either upgraded or upstaged. Around the same time, we did a study at our institution with about 4,000 prostatectomies, and it's when the NCCN guidelines said that we could watch favorable intermediate risk disease, and we said, really, is that something we want to do? We found very similar numbers to the European study that I just showed that was done a year later. The adverse pathology rate's about 30%, and back in the day when we were operating on low-risk disease, about 14% of those have adverse pathology. And if you look at unfavorable intermediate, just to flip the coin, about 52% of those patients don't have unfavorable or adverse pathology. So we need better tools to risk stratify these patients. I think when we started this course about 5 or 6 years ago, we were really concentrating on genomics in this space, sort of trying to decide who can we watch and how aggressive do patients need to be treated. But I really think in 2026, we're really applying these tools to almost every stage of localized prostate cancer. These are the guidelines for active surveillance from the NCCN. I just want to highlight a few of them. The first one is you should only order these tests if there's a potential ability to change management. I was at one of the dinners, this week, and there was a patient who had a PSA of 43 and grade group 5 disease and everything that you would not want to see in a prostate cancer patient. You probably don't need extra testing on that patient to know you're going to be very, very aggressive with him, right? So you only want to order these tests when it has the potential to change your management. Repeat molecular testing analysis is discouraged. If you have a patient with 4 groups of grade group 1 disease, and you order a genomic test and it's favorable, and now you're rebiopsying that patient in 3 years as part of your active surveillance protocol, and now they have 3 cores of grade group 1, you don't need to reanalyze that patient. And finally, these should not be ordered reflexively, in our opinion and the NCCN's opinion. We're going to concentrate on the tests Decipher, Prolaris, and GPS, mostly because they're recognized by the NCCN and approved by CMS for Medicare and Medicaid services, but there are other tests. And then we're going to really hone in on Decipher and on Artera. Those are the 2 tests that have been labeled prognostic/predictive by the NCCN. So which test should you use? There's a lot of pre-biopsy choices that Matt's going to go over, and the sequencing is very nuanced. You'll figure out what works for you. I told you the reason that we chose these 3 tests. And then as you're listening to the studies that went into validating and developing these tests, just decide what you think is the right endpoint for you. Is it prostate cancer-specific mortality with conservative treatment? Is it the ability to predict adverse pathology at surgery? Is it metastasis? And what's your prostate cancer volume? Should you be comfortable with just one chest test and use that? Should you change with the clinical situation? I really want to stress there's no best test. So this is a study that we ran at our institution. When I say study, it was just really an observation. But I had 22 patients, for whatever reason, got 2 tests. So one guy might have gotten a Decipher and a Prolaris, another guy a Prolaris and GPS, and a GPS Decipher, et cetera. And you can see the concordance rates were not very good. So it just made us say, geez, all these tests are supposed to be telling us the same thing, but they seem to be really different. And a much better study was done just this past year in December, where they took over 50,000 patients and essentially did the same thing we did, but with good numbers. And off of the Decipher database, they ran GPS and Prolaris, and their CAPA scores, correlation coefficients, were very similar to our 22 patients. So I show this just to say, you would think all of these things should jive. They kind of don't. And therefore, I think you have to be very careful to take one study that maybe used GPS and said you should do X, Y, or Z, and then say, well, my patient has a bad Decipher, so I'm going to do the X, Y, or Z from the GPS study. I think you have to be careful and sort of use the studies and the tests that sort of align. So as we go through today's presentations, we're going to use an index case to sort of make some points. So our index case is a 62-year-old man who comes in with a PSA of 8.2. We repeat, it's 7.8 with a free PSA of 20%, no past medical history. His brother had a radical prostatectomy at age 65, high-risk disease. This patient's DRE is unremarkable. He has mild LUTS and good erectile function. So are you recommending a biopsy with or without MRI? If you do an MRI, are you only doing a trust biopsy if the MRI is positive? Are you just going to follow that patient if it's negative? Are you going to do an adjuvant test such as 4K, PHI, exosome DX, et cetera, et cetera, et cetera? And with that, I'm going to hand over the podium to Matt.
Great. Good afternoon. Again, thanks for coming. This is about the 4th or 5th year we've done this course, and it's amazing how much new content there is every year. This is not one where we can just kind of pull up last year's slides, because so much does change every year, especially in the AI and genomics arena. In the pre-diagnostic space, we have movement as well. But before we dig into pre-diagnostic testing, it is always really important to emphasize that the starting point here is PSA, because these conversations start in primary care offices, and we got to recognize PSA is probably the best screening test in the history of oncology if we used it well, if we use it well. And historically, we didn't. When PSA was launched, we tested mostly men in their late 60s and early 70s, which is too late. We underscreened younger men. We overtreated low-risk disease, apparently even at the AUA a couple days ago, doing live RPs and Gleason 6s. And we undertreated high-risk disease, and 4.0 is the wrong threshold. Despite all this, we drove the mortality rates down 50%. So, the D recommendation we got in 2012 to stop screening was obviously baby out with the bathwater. We now have the C. The task force is starting to revise, and hopefully we'll come up with a better recommendation. The AUA's screening guidelines are very good, but primary care ignores them. To understand what to do with the post-op markers, first of all, realize that the median PSAs across the population are very, very low. So these are data from multiple cohorts over the years in Sweden and the US, the Southern Community Cohort Study, which is a large black cohort in the US. The medians across the population are around 0.7, 0.8. As you get to age 60, you hit about 1.0. And below that threshold, below 1 or even 1.5, PSA has about a 75% negative predictive value for high-grade disease, and men are done, okay? It is only those who have a slightly higher PSA, we should start thinking about testing at a much lower threshold than 4, and our algorithm at ECSF now is starting as low as 1.5 or 2. We think about second-line testing, not biopsy, but testing. So the list of options in the pre-diagnostic space are here. It is very hard to keep this slide updated, and the font gets smaller every year. But we have a number of urine blood tests and MRI. Maybe PET scan is coming into this space. Polygenic risk scores might be coming into the space, all to help decide what to do with an elevated or even marginally elevated PSA. And it's really important to recognize before we start getting into details that every single one of these tests is calibrated such that if the test is positive, we think you have a grade group 2 or higher. If the test is negative, it means either there's nothing or there's grade group 1. And in either case, you don't do the biopsy. So you are implicitly telling the patient, or maybe explicitly telling the patient, if you've got only grade group 1, we're not going to do the biopsy, we don't want to find it. So in this era of pre-diagnostic testing, grade group 1 is the very definition of an incidentaloma and should basically never be treated if it is all that we find. So in terms of evaluating the pre-diagnostic markers, it's important to recognize that to be valuable, a marker has to improve not just on PSA, but on all the information on the chart. So the age, family history, DRE findings, et cetera. Multiple risk calculators are out there validated to do this. And you got to be very careful about how the studies are done. Contemporary methodology has gotten much better. You got to make sure that the specimens are collected agnostic to the outcome, ideally agnostic to the test. So, a prospective biomarker repository that was set up without even knowing what the marker was. And, these days, like I said, I think most of the tests are being done to much higher quality studies than before. And again, the goal is not find prostate cancer. The goal is to find potentially lethal disease. So this is the long list of tests to consider before a first biopsy. I'm going to go through them briefly, but we have now 6 blood tests, 2 urine tests, and multiparametric MRI, all jostling for attention in this space. They all work, and they all, like I said, need to be considered alongside some sort of multivariable tool. This is the PCPT risk calculator, which is about the only thing I will actually leave Epic for during clinic to pull up to show a patient, because I've always liked this Smileygram as a teaching tool or as a decision aid for the patients. And when he first published this, Ian Thompson made the point that you can show 2 well-educated men this same 12% chance of high-grade disease. One may decide to get a biopsy, one may decide not to. Those are both reasonable decisions as long as the man has been educated and had the chance to make that decision. So let's drill into a couple of these. So 4K and Phi have been around for a while now. These are both blood tests. They're both based on isoforms of PSA, subsets of PSA. This is the list of the subsets from each of these tests. 4K does incorporate clinical data. Phi does not. The reporting format is a little bit different. These are 2 of the only ones that have actually been formally compared head-to-head. Most of them have not. This was about a 10-year-old study now from Tobias Nordstrom in Sweden, in Stockholm. And these AUC curves you always want to see up and to the left. I'll show you a bunch of decision curves as well, where you want to see up and to the right. Bottom line is over a baseline multivariable model here in blue. Both the Phi and the 4K are effective for predicting both the diagnosis of any disease and diagnosis of high-grade disease on the right. IsoPSA is a slightly newer test that is also looking at these isoforms of PSA. This one is based on the concept that abnormal PSA actually centrifuges a little bit differently from normal prostate-derived PSA. So when you actually extract these isoforms from the top fragment of the centrifuge tube, you get different fractionation than you do in the uncentrifuged tube. And they've got this complex formula for looking at the free PSA in the top versus the rest of the tube. And you get a pretty good NPV of 89% for finding grade group 2 or higher. Taking all comers, if there was a prior negative biopsy, that's 95%. And again, it improves over free PSA alone and over multivariable models in the published studies. There's the MyCheck test, which is one of the only ones left that still incorporates DRE, and that's a bit of a limitation because it does not work in the telehealth environment. This is just total PSA, free PSA, DRE, and a different protein called HE4. Again, 95% negative predictive value for grade group 2. You're going to see that number a lot. Okay, they're all typically in the mid to high 90s. This is ExoDX. This is the first urine test that did not require DRE. So there was SelectMDx, which is now off the market because the company took over Exosome, or vice versa. So Exo looks at TMPRSS2 ERG fusion in the urine as a full-length mRNA, and PCA3 in the urine using SPDEF as a control. No prior DRE required. So this is a home kit. This came out just during COVID. It was fantastically well-timed. We used a lot of it. So you just send the patient a kit, they pee in the cup, send it back to the company. Again, 96% negative predictive value for grade group 2 or higher, and beats the PCPT risk calculator and a variety of other multivariable tools here. These 2 here were just two different weightings of the 2 markers in the urine. The newest urine test is the MPS 2.0. The first MPS was just TMPRSS2 and ERG, not in the exosomal component, in the whole urine compartment. This is an update, so whole urine compartment, but does not require DRE. It's looking at 18 genes, and they have a 96% negative predictive value for grade group 2. In their paper, they had a sort of theoretical analysis of different markers and made the argument that you could avoid the greatest number of biopsies for negative outcome or grade group 1 using this test compared to the other ones on the market. So this has been out for about a year. We're using this one a fair bit as well at my center. Finally, there's Stockholm 3. Now, this is an interesting one. This is a blood test which incorporates the 4 4K markers plus 2 other proteins, MYC1 and MSBM, as well as a polygenic risk score. We'll talk about those in a minute, as well as clinical data, so the age, family history, and prostate biopsy history. all in a single blood draw, and this one is actually designed to work as a true reflex test. So the idea is you can send this as a specimen to the company. They run a PSA first, and if the PSA is under 2, they're done, and it's about a $70 test. If it's over 2, they will run all the rest of this for a few $100s. So in theory, this could work really well as a true primary care reflex test, and it's being studied in that context. I believe it's starting to be marketed in the US. I have not actually seen it out in clinical practice yet, but this is coming, and they've done some really big New England Journal studies, and you're probably going to be seeing more of this one going forward. So how do all these compare to multiparametric MRI? You can hear a lot about this from Dr. Pinto in a minute, but a reasonable meta-analysis a few years ago looked at a number of studies for MRI, which came out with about a 91% NPV for finding grade group 2 or higher. You compare that to the 95% for most of these urine and blood tests. And the other point with MRI is that the MRI almost invariably used expert readers here, and there's a big issue with reliability and inter-observer variability with MR, particularly in community practice. And also in the US, and only in the US, MRI is multiples more expensive than all these blood and urine tests. Everywhere else in the civilized world, a multiparametric MRI costs $300 or $400. Here, of course, it can be in the thousands. So here, and again, only here, the liquid markers tend to be more cost-effective. And you'll hear a lot more about that in a minute. I would also say on the imaging note, don't abandon ultrasound as a very good diagnostic modality. We had a study out a few years ago finding that it was really only in about 6.5% of the cases that the highest grade cancer was identified exclusively with the MR. So we rarely do a prostate biopsy without an MR first, but whether the MR is the best reflex test, I think, is questionable. And there was also the Optimum trial published last year showing equivalence of micro-ultrasound, if anybody's using that in clinic, compared to MRI. It does have its own learning curve, but if you don't have access to high-quality MR in your community, micro-ultrasound is definitely something to look at. And really important, all throughout this course, this is a really important theme, none of these is a binary test. Everybody wants a pregnancy test, and if it turns red, you take out the prostate. If it doesn't, you leave it alone. It's not the way the biology works. These are tests that help you counsel patients make better decisions. So what we do with these pre-op, you can sequence these any way you like. You can use MRI as your reflex test. That's the UK model. You can use a biomarker. You can use a marker to decide whether or not to get an MRI to guide the biopsy. You can flip it and get an MR and only get a marker if you see a PIRADS 3 or if the biopsy was negative despite the lesion. You can spend all the money, do all the things. Any of these is reasonable. This is the one we do probably most often at UCSF, but I would say even in my practice, if the guy has a lot of LUTs, I'll probably get an MRI first. There is certainly a lot of room for variability. So that's it. So we really need to be in communication with primary care on this whole topic. They need to believe that when they send their patients with elevated PSA, we're not going to rush everybody to biopsy and certainly not to treatment, but they should be screening. They should be screening everybody in midlife. This should be an unbelievably short conversation. They do not need a 15-minute shared decision-making waste of the clinical visit. They should just be testing, knowing that we are not going to rush down the overdiagnosis and overtreatment pathway. MRI can help guide the biopsy, so does a good quality ultrasound, and these markers are really quite valuable. So that's it for now. Any questions? We can, and as you go, we're a small enough room. If you guys have questions, you can raise your hand during the talks, or yeah, please. They do. So that's a whole different conversation. Everybody recommends shared decision-making. Okay, all the guidelines recommend shared decision-making. You can download a decision guide from the CDC that is 17 pages long. And you're supposed to talk about the risks of incontinence after prostatectomy before you draw a PSA. It is totally impractical and ridiculous to ask a primary care doctor to go through this in the course of a visit where they're talking about blood pressure and depression and everything else. And that whole incontinence after surgery thing, it's like talking to somebody about the risks of stroke after a bypass before you check their cholesterol. Okay, it's totally impractical. What the patient needs to understand from an SDM standpoint is that the purpose of PSA testing is to find high-grade disease. And that if you go down this path, we might find grade group 1, and that if we find that, it doesn't need treatment. That's the key thing they need to understand. And with that understanding, it makes sense for most people. Not 100%, but we don't do a lot of shared decision-making before you check a cholesterol. We do the shared decision-making before you go on a statin. And that is really the more relevant analogy here, honestly, because 75% of the population with a PSA is done. And the Malmo study would say you're done for decades with a single PSA under 1.
I, too, like the PCPT version 2 risk calculator like you do. I have some concerns. Some people have criticized it because the data was based on old sextant biopsies. How do you respond to that?
Yeah, it is definitely outdated. It's been updated a couple times. I'm not sure that there is a true contemporary validation out there. That's probably overdue. They also have versions of it that incorporate free PSA and I believe MRI, but not any of these other modern markers. That is overdue. anytime there's a test that gives you a specific numerical prediction of something, you have to be very careful. You know, the nomograms, like the 10 nomogram, have a plus minus 10% error bar on them. So, you know, the point is less about 7% as it is relatively low, relatively high risk, and that's sort of the way we frame it. But it's a really good point.
On the follow-up for the nomogram, the age limit is often at 50. What do you do for
Yes.
patients? Are you using it for patients below 50?
Yeah, that's a great point. You cannot. So yeah, the minimum is actually 55 in the PCP risk calculator. If they're younger, I'll just put in 55, knowing that their actual numbers are going to be a little bit lower. The younger the patient, the lower the likelihood of high-grade disease.
How important is the rectal exam? I find that in our residency, a lot of the residents aren't doing rectal exams anymore.
Yes. Perennial question. The DRE as a screening test is pretty useless in 2026, especially in primary care hands, and it's a barrier to screening. Men don't want to think about prostate cancer screening if it means a DRE. Now, if the PSA is elevated or they have LUTs, it's not a screening test, it's part of the workup of the elevated PSA. I will say, in this day and age, we're doing so much by telehealth, and they keep promising me version 7 of Zoom will let me check the prostate, but I still don't have that software. So, you know, I rely on the MRI or the ultrasound, and it's plenty. You know, the number of cases these days in the era of imaging that we're going to diagnose by DRE is really, really slim. So I think after the PSA, it still potentially has value, but it's not part of the screening algorithm. It is still incorporated in a couple of the calculators. All right, great. Let's move along. Pleasure to bring up Dr. Pinto from NIH.
All right. Pleasure to be here again. Thanks, everybody, for including me on this. I will say that the imaging part is becoming now a little bit long in the tooth, but I think we've adopted it. But we'll go through a few things that still are barriers, and I think Matt did a great job in explaining that there are barriers to imaging in prostate cancer. First of all, screening, staging, surveillance, treatment planning, and recurrence. You know, it's wonderful. We all trained at a time where, you know, we would not even think about going to the OR and managing a kidney cancer patient without kidney cancer CT imaging or MR imaging to understand who to manage, and how to follow up. And in many ways, prostate cancer just relied upon just a rectal exam, as we just heard, is really failing us, and then hopes that the cancer didn't spread when we got there. That's all changing now, which is wonderful. In regards to you know, this crossroads, you know, we're still under attack, I would say, in many ways. There are often people saying, you know, this is a cancer we die with, not from. We're over-treating this. And yet, you look at the numbers, and in 2025, we're still second highest cause of death in these individuals. And, you know, biomarkers and imaging, I hope, will improve this, but we haven't really, not really sure. Now, this is going to take some time, right? We're not taking care of pancreatic cancer or glioblastoma multiforme, where we, in weeks and months, make a difference. But, you know, we hope this is going to make an impact. We'll see. Don Coffey, a wonderful PhD scientist at Johns Hopkins, would say, you know, we see cancer of the prostate as a feline entity, but there are kittens and tigers, and you love the kittens, but you don't want to ever see the kittens, and you want to get the tigers before they become tigers. So in regards to ultrasound, you know, I agree with Matt, at some place like UCSF, where they are leaders in the field of imaging, yes, the ultrasound is very valuable. I think for most individuals, though, unfortunately, don't have the bandwidth that they have at UCSF. Ultrasound is just a bunch of black and little light-colored areas, and a lot of times you have to train yourself to look. But Matt is correct. When you do look, you do see, you find things. So I would say take a chance, spend a little time on the ultrasound, improve the quality of the ultrasound. You can actually play with the machine. If you don't know how to do it, you can talk the rep back into your office, and you can improve the quality of the imaging, and you do find areas that are often concordant with the MRI. But if you're moving quickly, like we did in the old days of systematic 12-core biopsies, it doesn't provide much help. And speaking of 12-core biopsies, it always drove us crazy when we did 12-core samples for a prostate gland of 30 cubic centimeters, and we did 12 cores often for something that was 300 cubic centimeters. So it's unbelievable that the percent volume of cancer within that prostate is under 1%, and the imaging really has changed that a lot, but it's still not perfect, and I'll go into why that's the case. So prostate cancer, how do we improve, how do we treat these cancers? Imaging gives us a chance to move from blind biopsies to targeted biopsies, but it's not the whole story. And the reason why is that, as alluded to before, the cost is prohibitive in many places, and not just this country, but many countries. And really, what impact is it having? It's uncertain, let's be honest. So this idea of moving from multi-parametric to biparametric is long overdue. Data now supports the opportunity to say this. But if you think about the origins of MRI, you have to layer in multiple sequences, hours, sometimes more than 1 hour inside the MR magnet. Coils in the rectum that were so painful, they would rather have surgery than that coil in the rectum. And as a chemistry major in college, I was a big NMR person. Spectroscopy is wonderful, but it takes too long. So if we go back and we get back to just a T2 sequence, DWI sequence, which is really what we need, costs will come down, health opportunities will be there, the patients will accept it better. Lastly, gadolinium in the contrast phase has some deleterious effects on the body. I mean, we do get gadolinium from many studies, but if we can avoid it, why not avoid it? And that's also important. So I leave this up there and pause for a second by saying, it's up to you as urologists to guide the radiologist in what you want for the patients. I think Dr. Wagner put it perfectly. You're in charge of the patient. What do you need? You don't order a test unless you change the management. If you feel the MRI is important to best improve how you diagnose the patient, either with a biopsy or staging afterwards, what parameters do you want, and guide the radiologist to do that and really be an active participant in that imaging test. I'll take a little PSA announcement here, and this is a different PSA, just to say that you need to look at the films. Quite often in the explosion of MRI, for which many of us on this podium were part of as we worked in this field, radiologists then ran to the community urologist and says, we're going to bring you MRI. And you get the report, and what you see in the report is not what's on the films, because we can't always rely on the radiologist to understand how to perform the imaging well, that's acquisition of imaging, and how to interpret it well. And both are pitfalls for failures. And you can see on this, in this example here, and I think if I move the mouse, it works. Perfect. This is an MRI that even my daughter, who's now going into college, could see that has distinct zones, different colors, different shades of black and white, and you can understand the anatomy. This is not an old MRI. This is a new MRI where the coil, the interface, and other parameters were done poorly. So look at the films, make sure that you see what's going on, and make sure that you're holding them to accountability. You think about the days of CT urograms as we move from IVPs. I lived with IVPs, carrying those films to my chairman, pulling them up on the screen, and CT urograms were going to replace that. And if you didn't look at the films, you realize that often the ureter was not filled with contrast. And if you look at the films, you realize that you took them to a retrograde and you found the tumor in the ureter. Same thing with MRI of the prostate. Look for those things. Now, the other thing, too, is this. We do see variations in interpretation. Now, this year at the AUA, there are quite a number of companies now offering AI assistance in how we interpret MRIs, how we partition or segment the MRI for different features, how we find cancers. But this inter-observer variability is still a problem. And so what I would say is this. Take the information with a grain of salt and still use it as a guide, but it's not the absolute truth. And this, as you can see here, we'll go forward and say that this is not unique to MRI. If you think about your biopsy grade, and you think about your Gleason grading scores, in particular 1 and 2 and 3, percent pattern 4 going from 2 to 3, or even any pattern 4 is often variable between pathologists, and sometimes it's variable between the same pathologists. And there are slides that you give back to the pathologist after a few years, and the read changes. MRI really is no different. Now, AI is coming, and the difficulty with this as an informed consumer is to realize what the FDA clears, what may be in your new biopsy platform, what may be offered to you by your diagnostic radiology company is not always benchmark on the best ways of performing it. So, for example, if a MR lesion system is detecting cancer based on the biopsy data, but the biopsy is missing the cancer, then that's actually misinformation going into the system. They call that dirty data. And so there's a lot of work being done by institutions at this meeting right now and overseas that are going to improve that. So hang in there, be a thoughtful consumer of MRI, but know it's going to get better in our lifetime for our patients. And to go back to the foundational lectures, foundational papers, we have to give credit to folks like Mark Emerton and UC London and his disciples. They beautifully designed trials to answer the questions that we think are obvious, but obviously we need the data to support that. And this, in brief, to save some time, the performance of ultrasound, as you can imagine, lags behind MRI, and this was level 1 data that came out that really changed the field in favor of MRI. Now, there's a lot of debate now as we move from transperineal biopsies from transrectal that, how much of an importance is the MR navigation? and I call that software navigation systems, because in the early days, and you know, I'm partly to blame for this, we really promoted transrectal biopsies. I saw that as what we did in my early days, just with MR guidance. As we understand the harms we provide patients with transrectal biopsies and the opportunity to decrease infection rate with transperineal biopsies, and has that become more commonplace in our office, even with the patients awake, we're seeing a trend now away from MR fusion and what's called cognitive fusion. And there is, I would say, inconsistencies in the literature about how well that gets to the target. I tell my colleagues is this: whatever you're comfortable with, if you're feeling you're getting a good diagnostic accuracy based on what you do in your office, you stay with it. But do not abandon the MRI. And if you do have software systems that can bring you MR, ultrasound, transperineal biopsies, work with them. There's many different companies out there, and pick what's best for you. And sometimes technology changes, so come to the AUA every year, go to the booths, and maybe change up if you need be. But at this point in time, the software systems do provide a very accurate and a very easy platform to perform these biopsies. And as Dr. Kuperberg said before, it's becoming more commonplace in our practice. These things contour regions between ultrasound and MRI. They give regions of interest. AI is being put into this. These are just a few papers that have come out over the years. And one of the papers that we felt very proud of was to understand the role of systematic biopsies, because there's a lot of pressure by the patients when they come to your office and say, your MRI shows me a spot on the cancer that I think is where my cancer is residing. Why are you going to poke my prostate 12 more times looking for other areas? Why doesn't the MRI just give us the answer? And this is kind of one of the questions we had. I'll skip to the diagnostic opportunities, but just say that the 12-core biopsies, about 8% of patients will have missed significant cancers. And in some patients, they may say, well, that's not high enough a number to go through the harms. In some cases, it actually is a little different. So we looked at the upgrading events. So this is the real question we had was, if I took a patient to surgery and I did a 12-core biopsy and I went and see how often that cancer was much worse, we understand that consistent with other prior patients published in the pre-MRI era, sometimes 30% of the patients or so will have worse cancer, right? As Dr. Kuperberg alluded to before, why would you go on surveillance if you think there's a worse cancer out there that you missed with your 12-core biopsy? And this was consistent. Now, we thought that the MRI would just solve this problem. And sadly, we were very, very wrong. MRI itself was not the answer. And there's many reasons to think that it'll get better over the years. If we repeat the study now, it could be a different number, but not much different, I think. I think the MRI still misses cancer. And in this case, if we did the MRI and what the patient asked us to do, which would be a targeted biopsy only, and we went to surgery, we still found maybe almost a 1 to 5 men a worse cancer out there. Those people would have been disadvantaged if they went on surveillance, possibly, or in the era of focal therapy, maybe disadvantaged in focal therapy. But when we, in the same biopsy session, did the MR targets and 12-core sampling, we found that the risk of missing an aggressive cancer worse than what we found on biopsy was very, very low. And that number down to about 6.7% is what we felt was still important to continue 12-core biopsies. I can tell you that we took a lot of heat from our colleagues overseas who really feel that a biopsy blind to tumor location with imaging should no longer be done. But at least in our practice, we give the patients the information and they can decide. And there's some nuances to this. If a patient strongly advocates away from the 12-core biopsy, we remind them that the risk of finding aggressive cancer actually is not very high. But we may bring you back, and if you want to go on focal therapy, we actually strongly advise this. So 12-core biopsy, is it extinct? Some would say overseas the answer is yes, and at least in our practice here it's not. At this point in time, we're moving to a point where it will go away. And I think at some point in time, we'll be able to say that as we bring in surveillance, focal therapy, and other non-whole gland therapies, these ideas of doing biopsies in the regions of interest will be more important going forward. Now, the guidelines, very fortunate to be part of this, really trying to put an idea of what we're doing with MRI, where are we today? Understanding that there are a lot of problems with the MRI today, as we listed before. Still, it's important to realize that when screening, level 1 evidence A, PSA screening, as we heard from Matt, is still priority number 1. The MRI prior to biopsy does improve the opportunity to find the aggressive cancers, although it's not level grade A evidence. It's still grade B, really strong. And I think the community of urologists is adopting this. So Also, there are times when the MRI isn't available, and you may say, let me just go forward with the biopsy, which is not unreasonable. So what about the repeat biopsy? You don't get the MRI the first time around for the reasons I mentioned. It wasn't available, it wasn't a timing factor, or whatever else. And you get an opportunity to say, well, I need to bring you back for a biopsy. I'm worried about this PSA trend. I still think you have cancer. I'm not really sure. And in those situations, the MRI does have an opportunity to kind of change the landscape of the diagnostic pathway. Now, if the MRI is completely negative, so negative predictive value, this is a hot topic right now, because in the interpretation of the MRI, it was alluded to before that the skill of the radiologist is paramount. And at institutions, with my colleagues to the left, you may feel very reliable upon the MRI interpretation. I know I do with my colleague, Dr. Turkbay, but that's not real world. So in cases like this, if it's negative, we still feel there's still a role for systematic biopsy. Again, this is a few years old. It may change in the future, but for today, we advocate and we do this as in our practice too. And it's unclear about the opportunity for software registration. The devices that exist are plentiful. They're a little bit unique to each other, and this is really the opinion of the experts. And when I see expert opinion, I don't put much value in it. Who are the experts? Who cares? And I just do what's in my practice. So get comfortable with that, but keep that in mind. There is no real evidence to support that. Now, PSMA. PSMA is exciting. It's getting reimbursed at a high level. It's coming through for our patients for risk of prostate cancer extension. It's shifting away from technetium bone scans that we kind of grew up with and other tests. And we're seeing it now being discussed for focal therapy, opportunities for screening. At this point in time, I think we're going to see probably more from our colleagues overseas about MRI screening than we offer about PSMA screening. But the real issue is when we have discordant tests. You heard from Dr. Wagner that there were some tests that he did in 2019 where the biomarker tests were not agreeable. And of course, the 50,000 patient study kind of proved what he knew a long time ago with fewer patients. We're seeing a lot of things, opportunities here where there's discordance also between imaging studies. And keep this in mind, it's something that we are studying, but by far we're not really endorsing at this time and going forward that this is going to be the opportunity for future care. Now, micro-ultrasound is exciting because it puts the tool back in your hand. The MRI story is wonderful. You write a script, they go away, they come back. If you have a good MR program with a good device, good sequence acquisition, and a good radiologist, a lot of ifs, then you can use that information. But now we actually have a tool in our hands. And actually, there was a non-inferior study that showed, as we alluded to before, that this actually is non-inferior to MRI, and it works out very well. You have to look at the value of that device in your office and then see how often that can shift away from MRI. I think actually there has an opportunity for that to kind of shift the landscape on MRI, although in our neck of the woods, we're seeing a lot of MRIs being done first. More to come on that. The opportunity to kind of understand the true predictive value of the MRI is often based on the whole amount values. This is some research that's been done in the past. I'll skip through it. And am I going the wrong direction? I think I am. Let's see here. I did. Okay. So we'll move on to active surveillance. Active surveillance has really picked up recently, and I think the biomarkers and also the imaging has played a role. A lot of harms have been avoided, but the opportunities to perfectly select individuals for surveillance, although over time it's surveillance and not watchful waiting. You have to understand that at some point you may act upon their treatment. MRI, if nothing else, provides a comfort level to the physician and to the patient that you're not putting them onto a treatment opportunity that's going to hurt them in the short term. Long term, it's unclear. There are opportunities to decrease the harms of active surveillance. Active surveillance comes with harms. We don't appreciate the anxiety that comes from patients when they get that biopsy, the next PSA, the next MRI, and we don't really appreciate often the harm of the biopsy and the number of course. These opportunities can decrease with imaging. And we have a trial at the NIH that we've looked at, now it's going on 17 years, where we looked MRI in two ways. One, as the ability to better stratify patients for surveillance. The other one, to better follow them. And this is just one example of a patient that you can get into your imaging trials where you say, listen, there's an area on the MRI that is clearly concerning for cancer. The biopsy shows grade group 2. and you can put them on a trial. And in this case, although we went 18 months, and normally for grade group 2, we don't go this long, we go 12 months for imaging. The PSA trend was minimal, and that's consistent with publications. You know, the lead surveillance trials have come from the West Coast, UCSF, from Johns Hopkins, and also Toronto, really kind of lead the field in this, and you would know that the PSA trends often are misleading. But that area did change on MRI and did get worse, and it was a grade group, Gleason grade 4 plus 4 equals 8. Now, this is what you have to worry about your patients. Did the window to cure, do you lose that window? Did it close on you? Or do you have an opportunity to still offer that patient a whole gland therapy? In this case, because the staging and the parameters of the MRI gives you information around pararectal extension, we can provide this opportunity. This is one anecdotal case that you can kind of glean from to say that in your practice you can roll through this. You know, we have to go through the PSMA trials for surveillance. This is exciting. We see an opportunity to better understand the biology of the cancer using PET imaging studies. I'll go one more further, not to discuss this year, but there are metabolomic imaging studies with MRI, one called hyperpolarized carbon-13 pyruvate imaging, which actually can look at the opportunities for that biological process to predict its progression on surveillance. That work actually was done initially at the NCI, but really championed at UCSF in the more recent years. And I think many institutions are looking at that as an opportunity to bring that to patients. I know what you're saying, gee whiz, another imaging modality. I'm fed up with this. But that one has an opportunity for biological activities. Now, treatment planning. It is remarkable how exciting the field of focal therapy is becoming. I think it was, you know, driven by patients initially, but endorsed by physicians. We have to be thoughtful in really selecting patients very well. Focal therapy is an option amongst other options for which you as a urologist can offer them all those, surgery or focal or surveillance. When physicians who can only do one procedure, even with well-intended, they will offer that procedure that they're best comfortable with. So for focal therapy, these opportunities exist in the background if you offer them surgery or, if need be, radiation. Imaging in these cases, we have one of our trials for laser, shows that anatomical location is very important. You have to select individuals that will give you the best chance of early success, just like you wouldn't offer robotic surgery to somebody who's got advanced T3 disease, T4 disease at that time, maybe later on in your career. So these are anterior lesions, anatomical location is very important. Next thing we have to realize is following patients, if imaging found the cancer, the biopsy proved it, you ablated the area, just like with kidney cancer or other type of solid tumors that we focally ablate, you want to use the imaging modalities afterwards also. And, you know, there is this feeling of, well, is the cancer returning? Is it de novo? Is it recurring? Is it a failure of modality? You know, for focal therapy, you can fail locally in the area you treated and retreat again, a second or third time. There are more than one bites at the apple, as they say. And this is where opportunity for PSMA PET and other imaging modalities could kind of help stratify your next step in therapy. You know, when we think about the opportunities, and we won't go into it today about, you know, node involvement, I would call it local regional advanced disease. PSMA PET is starting to perform very well. In this study here, the Condor trial, which is a really established study, you can utilize these imaging modalities to kind of better stratify patients for care. We have a growing cohort of patients in our region where radiation failure, primary radiation failures occur. Patients are young enough that they want to seek additional therapy. Our radiation oncology colleagues will offer them radiation again. Alternatively, you can offer them surgery. Understanding the risk of locally advanced disease is very, very important in those cases. And then we're back to the index case here. Do you want to cover this? Pep, you want to run this through this?
Sure.
Yeah, you want to flip over?
Just run through. So again, taking our patient forward. So the patient had a 4K test, as Matt mentioned, was an option. It was 23%. Cutoff generally for that is 7%, and a 23% risk of clinically significant disease. So had an MRI, PI-RADS 3, so equivocal. Had 8 out of 12 cores with grade group 1 with 10 to 75% core involvement for each side, so NCCN low-risk disease. in the region of interest also had grade group 1 disease in 65% of the core. So we're going to ask Dr. Cooperberg to step up and talk about germline testing in this situation. So candidate for germline testing, yes or no?
And then before I step down, I just want to get a feel, ask every year, MRI in your practice, you guys currently utilizing it or not just yet? So a few, not all. Yeah.
All right. So first of all, how many would order a germline test for this gentleman? How many would not? How many aren't sure? All right, good. Well, that's why we're here. The answer is yes, by the way. So why is the answer yes? So we talked, Pepe already introduced the general concept, genetic versus genomic testing. These are both very much part and parcel of what we're doing these days with managing high-risk prostate cancer and especially advanced disease. Again, genetics is what you inherited from your parents. Genomics is everything else that happens to the DNA and its regulation and expression and translation in the cancer tissue itself or in liquid specimens like blood. This is pretty well recognized at this point. The rates at which we can find germline inherited mutations in patients with prostate cancer, those with lower risk disease are pretty much comparable to the general population. About 3% we can find mutations in genes that are known to be associated with prostate cancer, like BRCA2, HOXB13, CHEK2, et cetera. Generally speaking, drugs that are related to DNA damage repair pathways. For those with higher risk prostate cancer, it is up to 6 to 9%, depending on what you read. And for those with metastatic disease, around 7 to as high as 16%, depending on the cohort. And this is, and the important point in this, the iceberg diagram here is, unlike breast cancer, where BRCA1 and 2 explain a high proportion of inherited breast cancer, prostate cancer is thought to be the most heritable of all the major solid tumors, even more so than breast cancer, but we don't have single smoking guns. BRCA2 is the one we recognize is the strongest driver, but it's not that common. Most of the heritability is in polygenic risk, where we don't really quite yet have the single genes identified. We know the tumors associated with BRCA mutations are quite a bit more aggressive. This is an older study just looking at the likelihood of metastasis-free survival over time, comparing mutated to non-mutated tumors here, 3x increased risk of metastasis. Now, the indications for germline testing from the NCCN, this is a separate guideline that they put out on germline testing, separate from the prostate one, and the list is longer and the font smaller every year. And this is why the answer to the index case question is yes. At this point, anybody with metastatic prostate cancer should be offered genetic germline testing. Anybody with high or very high risk disease according to the NCCN criteria. So anybody with a grade group 4 or 5, which is our index case, is eligible for testing. They recommend considering testing for anybody with intraductal or cribriform. We'll talk about that a little bit more in the next section. Those with strong family history. So it used to be anybody with a family history of lethal disease, lethal prostate cancer. Now it is anyone with family history of breast cancer less than 50, anybody with triple negative breast cancer, anybody with male breast cancer, ovarian cancer in the family, pancreatic cancer in the family, or even any family member with metastatic or high-risk prostate cancer at any age, any 3 relatives, and anybody with Ashkenazi Jewish ancestry. This gets to be a pretty big proportion of the overall population who are eligible. So the ASCO guidelines similarly recommends testing for anybody with metastatic prostate cancer, both genetic testing and somatic NGS testing, next generation sequencing. Now, as I said from that iceberg illustration, the known rare mutations like BRCA2 really only tell part of the story, and we're seeing an increasing focus on these so-called polygenic risk scores. These are looking at SNPs. These are single nucleotide polymorphisms that are typically associated with unknown function, regulatory regions of the DNA, et cetera, but they're known just from linkage analyses to be associated with prostate cancer or high-grade disease. You can look at dozens or hundreds of these things in combination to come up with these polygenic risk scores. And this is even being tested in the pre-diagnostic space here, and this is sort of on that list now of things to consider before a biopsy in patients who have elevated PSA. And this is one example study here looking at the positive predictive value of an elevated PSA based on your genetic risk, based on your polygenic risk score, ranged from barely 7 to 27%. So how you interpret the PSA might be quite different depending on the patient's underlying genetics. This is a similar study where they actually combined a polygenic risk score with rare variants, and basically you get complementary information between the two. So this is the likelihood or the odds of finding high-grade prostate cancer over time here, looking at deciles of polygenic risk score and whether or not a driver mutation was present. So the bottom line is having a polygenic risk score in the median as opposed to the low end, or the high end as opposed to the median, is basically equivalent to having a driver mutation like BRCA2. And if you have the combination of the two, both a high decile PRS plus a driver mutation, almost everybody, this is an odds ratio of 11, okay, eventually is going to be found to have high-risk disease. And this has even been studied in the pre-PSA setting. This was the Barcode trial, which came out last year in the New England Journal. This was a UK study that really tried to use polygenic risk testing at the time of screening in the primary care setting together with PSA. And they found that using the PRS would actually identify more high-grade cancer. The problem in this study, like many studies that are looking at alternatives to PSA as the first test, is that they use a threshold of 3 for PSA, which is too high. You know, if you're going to use a PRS or any of the other tests we talked about in the first part of the course, the threshold of interest really should be 1 or 1.5. So PRS definitely adds, but it probably adds less in the pre-PSA setting than using a lower PSA threshold. And the other point is I'm very skeptical the primary care is going to wrap their heads around this anytime soon. PSA is a $30 test. You can give them a threshold of 1.5 or 1 or whatever it is, yes or no. This is sort of interpreting deciles. It's a lot murkier. And to do this to decide in whom to draw a PSA just does not seem practical to me. The question comes up all the time, whether men with mutations can safely go on active surveillance. So there are relatively few data out there. This remains the only study. This was from Hopkins and Northwestern, which looked at the Hopkins active surveillance cohort, bifurcated between having a mutation in BRCA1 or 2 or ATM versus not having a mutation. And you can see the outcomes here. This is out to 10 years. Likelihood of reclassification to grade group 2 or higher, having started at grade group 1. And if you've got a BRCA1 or 2 or ATM, or especially a BRCA2, specifically, you see much higher rates of reclassification. The question is, what do you do with this? And do you declare that man ineligible for active surveillance and needs to go straight to treatment? I am personally not in that category. If you say, okay, 50% likelihood of upgrading by 6 years instead of a 25% risk of upgrading, listen, my feeling is, okay, so when you upgrade, we're going to treat. I think to say we're going to treat you with a 3+3 just because you've got a mutation is still going to drive a lot of overtreatment. Now, the caveat there is these folks do not get to drift off into watchful waiting, and they don't get to drift off into a less active, non-biopsy type of surveillance framework. I typically tell them treatment is when, not if, but when may still be years down the road, and I would much rather have my prostate out at 65 and 55. I'd rather have it out in 2036 than 2026. And more of these mutations are becoming actionable as we move into the advanced disease setting. So if any of you are taking care of men with advanced prostate cancer, this is absolutely part and parcel of what we do today in clinical care. The mutations we've been talking about so far are largely in the DNA repair pathways, either in maintenance of double-stranded breaks in DNA. This is where the BRCA family genes live, or in mismatch repair. This is the Lynch syndrome type genes. These are both at this point relevant to treatment selection. So PARP inhibitors, of course, along with platinum chemotherapy, very effective for patients with the double-stranded break machinery mutations, whereas checkpoint inhibition is particularly relevant for those with the Lynch syndrome family genes. And this is just one example of the many that are out there. This is from the PROfound trial. It's one of the pivotal PARP inhibitor trials, showing stratifying olaparib versus control here, stratified between not having a mutation at the bottom and having a mutation at the top. And if you've got a driver mutation here, you see a massive benefit for using the PARP inhibitor. If you don't have a mutation, it's not like the curves are overlapped. There is some efficacy here, but it's much reduced. And the FDA made the recommendation that these drugs only be approved in the setting of a mutation, which, if there were no other options, I think we could argue about. But in an era where we've got a rich armamentarium of treatment options for advanced disease, probably makes perfect sense. We should not be wasting time and toxicity and money on PARP inhibitors when there are other options. So this is an overall look at this point in the various disease states. I won't go through this in full detail, but in all of the CRPC, or now we're calling it APMR, right? Androgen pathway modulator resistant is the new PCWG4 recommended term that's going to replace CRPC. In all of these subcategories here, prior therapy, no prior therapy, this is the recommendations that are kind of out there based on mutation status or not. eligibility both for PARP inhibitors and for checkpoint inhibitors. Okay, so if we find MSI high or we find mutations in the Lynch family like MSH2, this is where pembrolizumab and other genes or other treatments are very relevant. Now, I mentioned under that NCCN guideline, a high proportion of men we diagnose with prostate cancer are eligible for testing. So are we actually acting on this? So there was a nice study a couple of years ago, took over 3,600 men who were referred for testing, of whom 17% were found to have germline variants, not necessarily pathogenic mutations, but either pathogenic or VUSs, variants of undetermined significance. And 30% of those with the variants would not actually have been indicated for testing based on the NCCN guidance. They had lower risk disease or less family history. This is another look at prevalence of pathogenic variants in the PROCLAIM study. This is a prospective cohort that Neil Shore put together from a number of the large LUGPA practices a couple years ago. And they split this into patients who did or did not meet NCCN criteria and did germline testing on everybody regardless. And the prevalence of hits was actually pretty similar, 9% if they, 8.8% if they met criteria, 6.6% if they did not. 42% of the overall patients with a variant would have been missed by the criterion. This is just looking at the PPVs and NPVs here. So the, and you're basically only at 50% PPV, NPV in terms of do the criteria predict a hit. So, our threshold for testing really can be pretty low, and we can be doing this quite liberally, I think, in contemporary practice. Who should actually order the test? How many of you guys are actually ordering germline testing versus sending them to a genetic counselor for the conversation? Versus really never talking about germline? So the trend, I think, is definitely toward the former, right? In our practice, even 5 years ago, we would send the patient for counseling and the counselors would order the test. They've been swamped. And our pathway now is we just order it and they get an automated referral to the genetic counselors if there is a hit, which I think has been a lot more efficient. And this is, the study I'm studying here just goes through these various options. There's also a number of different tests out there on the market, and the coverage is broader and broader in terms of how many genes are in most of these panels. This is an older paper from the Philadelphia Consensus. At this point, most of the companies have wider panels than this in terms of what's in the out-of-the-box germline assay. So in summary, take a good family history, but a really important point about family history is don't rely on it. Just because the patient does not have a family history does not mean he should not get germline testing, especially because a lot of men don't know their family history, or they just don't have a lot of male relatives, or they were adopted, or they just don't have great communication. All these things apply. So a family history is a very good rule in with a good PPV. It doesn't have a very good NPV. Just because the man does not have a known family history of prostate, breast, ovarian cancer does not mean you're not going to find something. So, think about germline testing. I would say if in doubt, offer testing. And just think about having an algorithm in your practice where you've got some kind of working relationship with the genetic counselors to make this work easily. And clearly, precision medicine, both in terms of germline and somatic testing, are going to have a rapidly growing role in terms of managing patients, both with high-risk localized disease and as we get into high-risk and metastatic disease. So that's it. We'll go back to the index case in a second. Questions? All right, great. So moving on with our index case. So with his PSA of 8 and a free PSA of 20%, as we said, he had a grade group 4.
Grade group 1.
Sorry, grade group 1. Ultimately underwent prostatectomy. Signed up grade group 4, was a PT2 with negative margins. Wait, I'm sorry, that was the brother, right. So what do we do for this patient now? So he gets an MRI, he gets a biopsy that shows grade group 1. He has this MRI that shows a PIRADS 3, okay? And grade group 1 is 65% of the biopsy tissue involved. He is a candidate for germline testing based on his family history. He gets a VUS, variant of undetermined significance, in bracket 2. So show of hands, who would offer this patient or recommend active surveillance? Who would offer definitive treatment? Surgery, radiation therapy? Focal therapy? Unclear? Shared decision-making? Okay, good.
And Genomic.
Always shared decision-making, right? All right, fine. Now, I'm going to launch in. This would have been Dan Lynn's next section here, but I'm going to pinch hit for him and get into this rapidly evolving field of both genomics and path AI. So, at the outset here, I hope it is clear, and hope this is not a new statement for anyone in the room. that it is of absolutely paramount importance that we risk stratify every prostate cancer at the time of diagnosis so that we can make appropriate recommendations in intensity of treatment from active surveillance for low-risk disease, focal therapy, immediate surgery radiation, combination treatment, or bringing in systemic therapy. And the clinical questions here at time of diagnosis, there's several. One of the biggest ones is for a patient who looks like they might be eligible for surveillance, do we surveil or do we think about immediate treatment? And if they are heading for treatment, how do we intensify that therapy? If we're going down the surgery path, do we do a lymph node dissection? If they're getting radiation, do we add hormonal therapy? Do we add pelvic radiation, et cetera? And again, we have many, many tests available. And in this post-diagnosis setting, we've got the 3 genomic tests, which have been around for over a decade now, Polaris, Oncotype, and Decipher. We also have the Artera AI tool. And there's a number of other AI tests rapidly coming down the pike. The other very recent news is in the case of active surveillance management. There's some new data to support Decipher in this space specifically. And for the first time, we have a urine test, the MPS active surveillance test. This is actually not in clinical practice yet, but just published in Journal of Urology. I'm not going to spend too much of time on it because it's not really out there yet, but this will be the first liquid test validated in the active surveillance space. So just like before you start ordering pre-diagnostic biomarkers, you need to think about the PSA in context of multivariable testing. Before we start spending money on genomic tests and AI tests, we've got to be using the clinical data available at the point of care well. And this is not how to do it well. Okay? The NCCN risk groups at this point should be taken out to pasture or taken around the barn and shot in the back of the head. This is from 1998. It is completely outdated, and in 2026, this is utterly inadequate to counsel patients. And if you take away one take-home message from this whole course, I hope that is it. First of all, the very low risk group is finally gone. This has been gone from the AUA risk groups and AUA guidelines since 2022. The NCCN finally dropped it belatedly last year. This has zero relevance in contemporary practice. If you find one of these, it means you didn't do the pre-diagnostic testing you should have done. This is the definition of overdiagnosis, and it literally comes from the Hopkins definition of indolence from Jonathan Epstein in like 1996. Okay, zero bearing in 2026. The problem with this is these boxes are drawn totally arbitrarily. This is not a linear predictor, and there is unbelievable heterogeneity within these boxes. And we don't need biomarkers to suss out the heterogeneity within these boxes. And we can do much better for free. This is the Capra score. You can use nomograms. There's lots of ways to do it. Capra is about 76% accurate. This is the same PSA Gleason score, number of cores involved in clinical stage, and we can predict likelihood of mortality, cancer-specific mortality up to 20 years, ranging from basically nobody to over 50%. And these separate very cleanly and linearly. This is one good way of using the clinical information. And before we order biomarkers, the biomarker has to prove benefit above a multivariable tool like this or like a nomogram. Just saying you can substratify the NCCN favorable intermediate group tells me nothing I didn't already know from a better use of the clinical data. And the other critical point, again, before ordering biomarkers, is we are in an era now where we're really starting to rethink histology. So we've known forever that pattern 3, grade group 1, is almost universally indolent. Grade group 5 is always bad. But the evolution of pathologists thinking about about pattern 4 has really been quite profound in the last couple of years. So I'm sure some of you have heard some rumorings, at least about cribriform histology. We're seeing that more and more on pathology reports. But as a next step, about a year and a half ago now, Justin McKinney, who's at the Cleveland Clinic with his team, published this paper basically dichotomizing the entire Gleason grading system into favorable and unfavorable histology. And it's really important to spend a minute on this. Unfavorable is Gleason 5, obviously, and then within the Gleason 4 categories, large cribriform, so not all the cribriforms, but large cribriform, intraductal. Okay, those patterns we've been seeing for a few years, and then 3 less common patterns, which I had honestly never heard of before this paper came out, but we're starting to see at the UCSF reports in a couple of other centers. Everything else is favorable. So all the pattern 3s, but also the fused gland and the poorly formed gland versions of pattern 4, glomerular pattern 4, even simple cribriform pattern 4 are favorable. The reason this is so important is I have been doing biomarker work for about 15 years. I have never seen survival curves split like this. This is about 450 RP cases from the Cleveland Clinic with, you can't see it from the back of the room, but this is 30-year outcomes here. Okay, so this is recurrence, metastasis, mortality. Out to 30 years, there are zero metastatic events in the patients who have favorable histology. Whereas the unfavorable group, almost everybody falls off this curve, and at 25 years, it is still not flattened. Okay, so if you want to think about what is real cancer, what is not real cancer, it's hard to imagine a starker dichotomization than this. And even when you break down high-stage disease, this is T2, T3, T2, T3, and T3B here. There's obviously not very many T3Bs that are favorable, but they do quite well. This is big news, and this is not a standard of care yet that all the pathologists are following, but we're seeing this more and more. It is one reason we highly recommend patients get their slides re-reviewed by an academic pathology department, even if they're not getting managed clinically in an academic center, because these details about the pattern 4 are incredibly, incredibly important. And a quick note on the fused gland subtype, this is where the pathologists disagree with each other, not because one is right and one is wrong, but it's really subtle. And the calls between a Gleason 3-3 and a 3-4, where it's 5% fused gland version pattern 4, this is often a debate internally with the pathologists. Is this real, or is it just a sectioning artifact? And they will often disagree with each other. And again, this was a study where some of the top geopath folks in the country would trade cases, and if they thought it was easy, their kappas, the agreement scores were good, about 76%. The minute one of them said this is hard, I can't really tell, 27% is terrible. Not because Jeff Simcoe's right and Larry Chu is wrong. It's because they have styles, and just like one of us might go a little wider on the nerves, one of us might go a little tighter on the nerves, based on our own clinical experience. It's the same thing. There's a lot of art in this. AI is coming very hard and very fast for this, but for the time being, there's a lot of subtlety here. But it turns out it doesn't matter. The ones where we're arguing about 3-3 versus a little bit of 3-4, clinically and biologically, they are equivalent. And this becomes incredibly important when we talk about these outdated NCCN risk groups. The guy on the left here, the guy on the right, totally different patients. They are both quote-unquote unfavorable intermediate risk. The one on the left, 76, low PSA density. He's got a low-stage disease. He falls into unfavorable only because he's got a little bit of 3+4, plus more than 50% of his scores are positive. And even though most of that 50% is low-grade disease, under this very unhelpful, unfavorable intermediate definition, because he's got 2 hits, he's unfavorable. And if somebody's really following the letter of the law and the guidelines and radiation, he's going to get 2 years of hormonal therapy. It is honestly ridiculous in 2026. We can do a better job classifying these folks with Capra, again, or a nomogram or anything else. The guy on the left, I would say, is a chip shot for active surveillance. The one on the right very likely has metastatic disease, needs a PSMA PET, needs multimodal therapy, completely different patients, and yet we put them in the same bucket. So all this before we start talking about the biomarkers is to really stress the point that we need to make sure that the markers, before we start spending money on them, beat a true use of a comprehensive look at the information we already know for free. So with that said, do the markers clear this bar? The answer is clearly yes. All of them have been shown, all the genomic tests have been shown to improve above and beyond multivariable risk classifiers. And this has been shown very consistently over the last decade and a half in many, many studies. I'm going to go through some of the updated data on each of the tests that are out there. So and actually show of hands, who uses Prolaris in clinical practice? Oncotype? Decipher? Artera? All right, good. Almost everybody represented. Perfect. Great. And absolutely our goal here with this course is not to advocate for any one of these over the others. These are all out there, and they're all valuable. And there have been almost no head-to-head comparison studies in all these years comparing them. They have their strengths and weaknesses. Prolaris is a PCR test based on 31 genes, all in the cell cycle progression pathway. It was originally designed to predict mortality in untreated patients, but like all the tests, all 3 of these tests was originally designed for one outcome and has been validated for pretty much all the other relevant outcomes as the years have gone by. So, at this point, there's about 10,000 patients reported here. What's interesting about Prolaris is they have always explicitly combined the genomic information with clinical information. So the original post-op test was combined explicitly with the Capra-S, which is the post-op version of the Capra score. They've looked at Capra. They now have a slightly refined version of the clinical data in their pre-operative test, but they report out a score that explicitly combines the genomics with the clinical information to give you a likelihood of disease-specific mortality and metastasis. This is a look at their report. I have a lot to say about all these reports. I'm not a big fan of any of them, to be perfectly honest, and the problem with this one, and I'm just going to highlight this here, there is no molecular test or any other test that should tell your patient what to do or should tell you what to do for your patient. And they have all done this over the years, and I've yelled at all of them every time they do this. The Prolaris should never tell you, this guy gets active surveillance, this one gets single modal, this one gets multimodal. That is not the way the biology works, and it is not the way clinical medicine works. Okay, these tests are incredibly helpful, along with everything else. Before you recommend this guy for single modal versus multimodal therapy, you want to know his Gleason score, his Prolaris, his number of cores involved, everything clinical, his age, his comorbidities, his priorities, his concerns about sexual function, his baseline IPSS, and everything else that is not going into this algorithm before you make a clinical recommendation to the patient and solicit his preferences in terms of what he wants to do. So, again, the reports are kind of written by the marketing departments for better or worse. So no matter how good the tests are, you have to be very careful about what we actually present to the patients. So I tell folks to ignore that corner of it, but what you do get that's very helpful is the risk stratification here. This is where this patient is in relation to others, sort of peer patients according to clinical risk. And you get recommendations here, percentages. And again, you have to be a little bit careful with the percentages. Is somebody really going to make a difference a different decision at 3% versus 5%? I think they're very helpful in terms of a broad sense of, you've got a couple percent risk versus a 15% risk is much more important than drilling down to the second decimal place. So a study that Dan ran about 7 years ago now came up with the threshold that they use in drawing that active surveillance box is based on two large studies where they had this combined, the CCRs, the combined clinical and genomic score, and they looked at patients out to 10 years here and found that if their threshold on the CCR score was under 3.2%, they did not have a single metastatic progression event in 10 years, and that's very favorable. Obviously, these are always somewhat arbitrary thresholds. How good does it have to be to make a hard recommendation? This is a clinical decision, not necessarily a box drawn on the report, but it is certainly very reassuring. Now, of course, in active surveillance, you need to know outcomes way past 10 years, but certainly in terms of what do you do first, what do you do at this moment for the patient, yeah, if they're under the threshold, this is very reassuring. I think the issue is that if they're a little over the threshold, well, what if you have a 2% chance of progression at 10 years? Does that mean you need immediate treatment today? Probably not. Just like the BRCA2 example, surveillance does not mean never treat. Surveillance does not mean go home and forget about it. Surveillance means not today. And we have to be very careful about all these tests that we don't drive men who have grade group 1 or minimal risk grade group 2 into treatment. We should be using these to modulate intensity of surveillance and pick decisions for borderline cases, not to justify overtreating low-risk disease. There have been a number of these decision change studies out there. Some of them are better quality than others. The FDA likes to see these from the companies, so most of them have done them over the years. And generally speaking, everybody shows that when you order a test, you change people's minds and change what they do. What's really hard to know is how often was this in the right direction. And most of the time, we've found de-intensification of treatment with the use of a test. You have to be very careful about any decision change study that uses historical controls, because of course, as time has gone on, we've gotten a lot better as a specialty about doing more active surveillance for low-risk disease. Now, the multimodal threshold, again, the limitations of the way it's presented aside, where that threshold comes from for single modal versus multimodal therapy was based on a different large cohort. Now, this was 15,500 men with unfavorable risk disease by the NCCN. And they found this threshold of over 9% prediction of metastatic disease in radiation patients would validate this idea of multimodal therapy. Now, again, it's a little bit arbitrary. This is not getting to the threshold of a predictive test. Everything we've talked about so far is prognostic, meaning you can take a patient with a clinical threshold, clinical definition of risk, and the biomarker can shift us up or down in terms of risk, who's got a higher risk tumor or a lower risk tumor, more or less likely to progress to metastatic disease. That's a prognostic test. To get to a predictive test, we want a test that will really tell you what to do, meaning if you're below a threshold and you add hormonal therapy, the guy will live longer. If you don't give hormonal therapy above the threshold, he will not. Conversely, if you're below the threshold, you should not add hormonal therapy. That's a predictive test. This study design does not quite get us to that point. It tells us that if you're over the threshold, you're more likely to get metastatic disease. So sure, it stands to reason that you should intensify treatment, but it's not quite the same thing as actually testing it in a setting where you have the outcomes with and without the intervention, like hormonal therapy. This study also made the point that once you have this combined clinical genomic score, the NCCN risk groups themselves basically fall out as prognostic, which is not really surprising because the information is actually reflected better in the CCR score itself than the NCCN risk groups. And this finally is the original development studies from Jack Cusick in these conservatively managed UK patients. This was not active surveillance. This was just literally watchful waiting. But this does give a reasonable estimate of likelihood of progression to metastatic disease without treatment over time. Again, with the caveat that these are patients diagnosed a long time ago. And you always have to be careful about those percentages. Almost invariably, this is true of the other tests as well, the numbers overestimate the risk of progression relative to a similar patient diagnosed today, because 15 years ago, these were folks diagnosed by sextant biopsy with no image guidance, with the older Gleason definitions. You take the exact same parameters today, somebody's going to do a lot better. So that's Polaris. Oncotype was the second one released. This is the Oncotype DX GPS test. This looks at 17 genes. It's 12 genes in 4 different pathways here: androgen signaling, cellular organization, stromal response and proliferation, normalized to 5 housekeeper genes. This one was particularly well optimized to really small amounts of tissue, and initially when the test came out, this was really the only one that would work if you had, just a 0.5 millimeter of cancer. We're of course trying not to find cancers that are only 0.5 millimeter these days, especially with image-targeted biopsies. We tend to find much longer involvement of the cores. But nonetheless, that was a technical advantage that this test had early on. Again, it's based on RT-PCR on these genes only. They also optimized this test early on for heterogeneity, and this is unique with this one compared to Decipher and Polaris. They started with 700 candidate genes that they thought were interesting from a cancer standpoint, and in the original refinement studies, they specifically selected genes that were predictive across multiple foci of the cancer. This was work led by Eric Klein, who gave the SUO Huggins talk yesterday. So that also is unique for this one compared to the other tests here. Only genes that were predictive in both the dominant and the highest grade area were included as they refined down the gene set. So this was our validation study at UCSF years ago now. Does the GPS test predict above and beyond a true multivariable score like the CAPRA or like a de novo multivariable model we built? The answer was clearly yes. And this was the original. This test was originally sort of calibrated to predict adverse pathology at prostatectomy. And what we showed at the time was this was able to shift risk up and down from a baseline prediction based on the CAPRA score alone. And almost half the patients had at least a 5% shift up or down in the prediction of adverse pathology based on the incorporation of the GPS test together with the CAPRA score. They did a big validation study not that long ago in the Kaiser cohort, 6,000 surgically treated patients, and it was predictive for both metastasis and prostate cancer mortality. And this is a look at the 10-year risk of metastasis and they drew thresholds at this point. This was for every 20-point increase in the GPS test here. And these were the 10-year risks according to the NCCN here. And again, it's another, according to NCCN risk group. So it's another good way of looking at interaction between the two. So low risk disease, high GPS is not the same as having higher risk disease together with high risk genomics. The two do interact together. And again, emphasizing the point that you should not be looking at the genomics in isolation away from the clinical data. So this was prediction for metastasis and for cancer mortality here. And importantly, they've driven a threshold of 20 based on the observation that there were no patients who had a metastasis within 10 years and had a GPS threshold below 20. And it's been harder for the genomic companies to come up with thresholds than for the pre-diagnostic tests, because for all the pre-diagnostic tests that we talked about before, this 95% negative predictive value that makes them very clinically actionable as sort of binary tests, it's because the implication is pretty straightforward. If it's negative, you just don't do a biopsy. Okay, and that's a sort of one-time decision. You can keep following PSA, you can repeat the test. There's not that much downside. And the tests are perfectly happy to have pretty low positive predictive values. I emphasize the NPV in all those pre-diagnostic tests because the way we're using the test is to rule a patient out for biopsy. They all have kind of marginal positive predictive values. They're in the 30s, 40s, maybe up to 50%, and we are all fine with that. Okay, if we do an MPS2 or a PCA3 or a 4K or whatever, and we do a biopsy and it's negative, okay, the guy had a biopsy he didn't need. It's not the end of the world as long as he didn't get a septic event. If we find grade group 1, well, that's not great either, but we can do surveillance. The implication is not that bad. It's much harder here to actually get a threshold. because the implication is much harder and because the conversation is much more ongoing. It's not a question of treat now versus never treat. You know, the active surveillance conversations are much more nuanced. The conversation repeats every time we do a biopsy. And again, we're incorporating things like PSA kinetics. We're incorporating lots of subtleties in terms of quality of life and comorbidity, none of which are really reflected here. So it's a lot harder to use these tests in a binary way, the way we do the pre-diagnostic tests. And even the pre-diagnostic tests, by the way, I didn't make this point when I gave that part of the talk, even those tests that do have a threshold, they're still continuous variables. So ExoDx, for example, has a threshold of 13.5. There's a difference between being 13.7 and being 60 on that test. And how we actually interpret the results and counsel the patients really does vary depending on the details. So, you know, GPS, like all the tests, is now validated as a key predictor across all the clinical endpoints. This is a look at its prediction in terms of biochemical recurrence for intermediate and high-risk patients treated with prostatectomy. This was from Brian Helfand in PLOS ONE a couple years ago. These are the HRs, and for every 20-point increase in GPS, very similar to our original validation study in 2014, about a doubling of risk with every 20-point increase in GPS. They've also looked at this after radiation therapy. Here, the hazard ratio was even higher. 3.6 for biochemical recurrence after radiation, 4.5 for METs, and over 5 for cancer mortality. These are pretty substantial for every 20-point increase in risk. And this was on multivariable analysis, adjusting for multiple clinical parameters, not just the NCCN risk group. And this was dichotomizing the GPS here at 40, not 20. So again, you have to keep these different thresholds in mind. So this is dichotomization at 40 for BCR, metastasis, and mortality, and it works. So this is their new report. They used to have this report with, you know, box shifting from the NCCN, which was, you know, that used to be the one I held up as kind of the bad example. I think the new one is much better. Again, it shows where the patient is in relation to his sort of risk peers, if you want to think of it that way, for lower or higher risk disease. And I think this is, to me, has always been a good way of presenting the information. You know, we already knew a lot about you based on your clinical information. Now we've got this genomic test. This is what it told us that we didn't already know. This is how these things should be interpreted and used in clinical practice. So this is an example of the low-risk report here. You know, again, it gives you likelihood of adverse pathology of prostatectomy and some numbers in terms of downstream outcomes, and some further predictions here of other outcomes on the back page. The higher risk report here focuses more on the outcomes in terms of metastasis and mortality, but they don't really focus on the thresholds here, which I think is very much appropriate. And again, this is the questions, surveillance versus treatment, and intensification of treatment. But just like Polaris, there have been no prediction studies really done with the GPS. In other words, it can't quite tell you what to do with any of these questions. It just tells you, think harder, think in terms of higher risk, more intensive therapy, lower risk, de-intensified therapy. So finally, there's Decipher. This is a 22-gene classifier. This is distinguished from the Polaris and the Oncotype in that this is not just PCR. They're running an Affymetrix whole transcriptome array on every clinical specimen they get. So they've got the whole genome. The Decipher score itself is the 22 genes. They've gone through a few different versions of how the genes are actually weighted. So I think they're up to version 2.3 or 2.4 at this point, but it's always been the same 22 genes. But they've got the rest of the genome in the background, which has become a really remarkable bioinformatic resource as the years have gone by. So these genes were chosen purely computationally. And when the score came out, they didn't even know what all these genes were. 3 of them we now know are non-coding. So there is a lot of data in the background available to the company and to collaborators. This is by far the most extensively validated of the tests out there. There have been dozens of validation studies. This is across adverse pathology, BCR, metastasis after surgery, metastasis after radiation, cancer mortality. In every case, the gray is the clinical standard of care. In some cases, that was just NCCN. In some cases, it was something better, like the CAPRA. And then the blue bars are the addition of the Decipher score. Invariably, it does add prognostic information above and beyond the clinical baseline. And because there's much more data from a research standpoint and from the standpoint of the Decipher grid, which is a supplemental report that they will give you on request, there's a lot more you can do with it. So this is a look at our relatively low-risk surgical patients several years ago at this point, calculating 25 different risk scores from the Decipher data. And you can look and see sort of where they are concordant, where they disagree. And we found, a fair number of these were Gleason 3 and the blue were Gleason 4 patients here. There were some 3+3s with pretty substantially aggressive disease based on multiple scores. And again, a lot of these are now part of the GRID supplement that you can get with the Decipher test. So this is a look at the distribution of Decipher scores from their database. They don't have a database. I think they're now actually up to like 250,000 nationally. It's a very large informatics resource. When they got to 150, they put this out. So by grade group, this is the distribution of Decipher scores. They had these thresholds like everybody else at 0.45 for low to intermediate, 0.6 for intermediate to high. Again, I don't love the threshold. It's a continuous variable, but this is how it breaks down. Of course, on average, with higher grade disease, you see higher genomic scores, but there is certainly quite a bit of heterogeneity. So this is their report, and like with all of them, I tell patients to ignore everything except the number. There are these predicted responses to predicted rates of metastasis and mortality down here. As with the other scores, I find these freak patients out, and they are higher than I would have any expectation that they would be for today's patient because they're coming from patients diagnosed 10 years ago. And you get exactly the same clinical parameters 10 years ago. That patient today is going to do better because the Gleason scoring is different. The overall burden of disease is lower because it's an image-guided biopsy paradigm, and we've got 12 new treatments for advanced disease that we didn't have before. And surgery is better, and we're using more postoperative radiation therapy. So, I really caution folks not to overinterpret the specific numbers. What matters, again, is where they are in the spectrum of their peers in terms of risk. So, as with the other tests, the decisions that we're trying to modulate here are treatment versus observation and intensification of therapy at the time of treatment decision. So, this was a relatively early look at the folks who qualified with the NCCN favorable intermediate risk decision here, likelihood of adverse pathology at time of surgery. This was in the first few thousand patients that were in the GRID database. If they were Decipher under 0.6, that was only 13%. If they were Decipher high, it was over 40%. Again, I don't necessarily agree with the interpretation that they're not good candidates for surveillance, but I would say they need much more aggressive surveillance. And I tend to tell folks who have low-grade disease but a high Decipher, this is a bit of a sharper crystal ball in terms of what might happen over the next 5 to 10 years. And treatment is probably a question of when, not if. But again, I'd rather have my treatment 5 years, 10 years down the road than immediately. And there's also a literature that even a 1 year or less than 1 year period of active surveillance for a patient that goes to treatment very quickly, even if it makes no difference in terms of their clinical outcomes, that patient has less decisional regret. And this has been shown in several studies because he feels like he's not rushed into a decision. He's had time to come to terms with it. So even the patients with high-risk genomics rarely need to be in a rush to therapy. This was a nice look at the Decipher use in the Music Consortium. This is the statewide initiative across the state of Michigan where they've been collecting data from pretty much all the urology practices in the state. And they have a very detailed active surveillance data collection effort and surveillance roadmap. This is a look at the time on active surveillance according to Decipher low or Decipher low or intermediate versus Decipher high. Now, of course, it's a bit of a self-fulfilling prophecy because the patients who have high Deciphers are more likely to get recommended to get treatment, just as they are more likely to ultimately have higher grade disease. But nonetheless, it's a pretty substantial difference, nearly 2 years in terms of the durability of surveillance based on the genomic test. So what about treatment intensification? Now, here, this is one of the two tests that really does have some predictive information that we'll get to in a minute. So there's a lot of interest, obviously, in avoiding hormonal therapy for patients that are going down the radiation path. This is a look in some of the older RTOG cohorts by genomics, by low intermediate versus high risk disease here. What's the likelihood of metastasis with radiation alone? And for low Decipher, it was basically 0 at 10 years, as opposed to 10 to 15% for higher risk disease. So, again, making the argument that these patients can probably avoid hormonal therapy as they head to radiation. Now, of course, this is a relatively low-risk cohort, so a lot of these folks probably didn't need the radiation either if we're thinking about a 2026 path. But nonetheless, in terms of de-intensification, this can be quite helpful. And this actually is in the NCCN guideline now as a statement. Specifically, choice of short-term hormonal therapy, yes or no, may be guided by the genomic classifier, by the Decipher score here. In terms of higher risk disease, this was 3 of the large RTOG trials. looking, again, at incidence of metastasis over the long term, based on low versus high Decipher. It is certainly able to stratify patients in terms of risk. And again, makes the NCCN here suggesting ADT duration might be modulated, short versus long term, based on whether you're below or above this high-risk Decipher threshold. I'll show you in a minute why I think this actually has a little bit more specific credibility in that case. This is out of STAMPEDE Arm G, which was the addition of abiraterone to hormonal therapy for patients with early metastatic disease. Looking at standard of care, so this was the randomization of standard of care versus standard of care plus 2 years of abiraterone. And they were able to look retrospectively at the STAMPEDE data to determine the absolute benefit of this intensification based on Decipher score. So this is overall survival here and metastasis-free survival here. And the bottom line is that for patients who have low-risk Decipher here, there's a difference, but it's not all that substantial. And you are facing reasonable toxicity burden, whereas patients with higher risk, you do see these much larger deltas. Now, the ASCO has a guideline that Scott Eggener led on this topic a couple of years ago, which really did make the point that these markers can help improve risk stratification, but they don't need to be ordered for every patient, and they should only be ordered when it is going to affect clinical decision-making, which is a very good recommendation. They're not recommended for routine use, except to the extent that they have been prospectively tested and shown to improve long-term outcomes. Actually, the one slide that I don't have in here is from they ran one other RTOG analysis in the setting of using hormonal therapy with radiation therapy after surgery. There was a very substantial predictive benefit in the sense that if the Decipher score was low, if the Decipher score was high, there's about a 10% absolute mortality benefit to treatment intensification with hormonal therapy on top of radiation therapy in the post-surgical setting. On the other hand, if Decipher was low, not only do you not see that metastasis-free survival benefit, there was actually a lower overall survival because you're exposing the patients to the toxicity of 2 years of hormonal therapy, and they're not getting a survival benefit from the cancer standpoint. So that actually gets us to this predictive threshold, and that's the summary here. And it's really the only one of the three that has cleared that threshold because they've done analyses in these old RCTs where the questions were really laid out. Hormonal therapy, yes or no. So finally, let me spend just a couple minutes on pathology AI. So this space is obviously exploding. This is from the FDA website. It's a listing of the FDA-approved AI-enabled devices and tools year over year. So 10 years ago, there were basically zero. Now we are up to 1,350 as of late 2025. Over 1,000 of these are in the radiology space, and there are a few dozen for prostate MRI alone. There's actually only 8 in all of pathology, one of which is the Artera test that I'm about to mention. But the point is this space is exploding, and it's moving, honestly, faster than anybody can keep track of it. There are radiology tools that are popping up built into Siemens scanners that nobody's even seen any published data on. It's kind of amazing how fast some of this is moving. So why digital pathology? Dr. Pinto already talked about the radiology AI evolution. Obviously, a lot of the same principles apply in pathology. There is variability in pathologist interpretation of H&E images, just like there's variability in radiologist interpretation of scans. But also, a computer view of pathology may well pick up subtle findings on the H&E that the humans don't. You know, we've basically been looking under the microscope the same way for 150 years, looking at things like nuclear morphology and glandular organization and things that human eyes detect. There are things like, you know, angles of collagen fibers and the distance between nuclei and things that a human will never really notice and certainly would never have the patience to count. And if you compare this in principle to genomic testing, you're not burning tissue. We're not destroying any tissue. The turnaround time can be a lot faster, and in theory, it can be a lot less expensive. And for all this, it might be a lot more globally accessible. So, you know, all the genomic tests we've talked about are really very US-centric. There is some very limited availability in Europe, almost nothing anywhere else in the world. Whereas, you know, a PathAI test, as long as you have an internet connection, you can send, you know, an H&E from anywhere in the world as long as you've got a scanner. So the one that is by far the furthest along is the Artera test here. This is in the it got into the NCCN guidelines very quickly after launch because they had access to a lot of these RTOG cohorts, so phase 3 cohorts, mostly from the 1990s, but it enabled them to publish with a high level of evidence very quickly to get to some of these prognostic and predictive questions that we've been talking about. So it's not a pure image test. So they actually run a couple of different AI algorithms here, one of which is on the clinical data, the other is on the digital pathology. Then they merge these into this multimodal artificial intelligence score, this MMAI score, which incorporates both clinical data and the images to give you a final AI score. They are working on deconvoluting this and getting the information from the image alone, which I think long-term is going to be important. But for the time being, it incorporates both. So these are the input clinical variables here: age, baseline PSA, and stage. They've actually taken Gleason out in the more recent versions of this, and the biopsy tissue here. They can do all the usual predictions in terms of clinically relevant outcomes. And it was trained and validated on this set of RTOG cohorts. So these were trial cohorts from the 90s and early 2000s, all initially in patients treated with radiation therapy. And for their prediction studies, very similar algorithms, very similar variables, but a different RTOG cohort, because again, the question for prediction is the same one we talked about for Decipher, which is intensification of radiation therapy with or without hormonal therapy. So this is the prognostic performance. Now, I will say Artera has really only held themselves up so far against the NCCN as the comparator here. We have a study coming out very soon from UCSF where it does hold up against a true multivariable comparator, but those are not quite out yet. So this is NCCN alone, which is a low bar, versus the multimodal AI incorporating the clinical plus imaging information. And not surprisingly, it does a better job at predicting all these various outcomes. Again, this is in part because the NCCN is such an easy straw man to beat. They have done some interesting explainability work here, and I'm going to talk about the black box aspect of this in a minute, where the pathologists have done very detailed annotation, tile by tile, of what's going on across the H&E slides. And you can start to do these very interesting clustering analyses here to start to figure out what the computer is actually looking at and what it's seeing. And this is going to help us really get to this explainability concept of what is really going on in the computer, because it's a really important question as we go forward here. Now, this is prediction, and this is I think where the test is by far the strongest so far, is this predictive question of do we add hormonal therapy to radiation therapy? So this is these large RTOG cohorts here. And in the overall trial, this is the original report from the 2000s here, addition of short-term ADT to radiation therapy alone improved 15-year metastasis-free survival, and that's what got combination therapy on the map years ago. So they stratified by the MMAI score here, and you see this very profound difference. If the score is positive, they give you a specific prediction for ADT, and if it's positive, you have a large absolute difference favoring the combination of radiation therapy with hormonal therapy to prevent metastatic disease. On the other hand, if the test result is negative, these curves are absolutely overlapped. There is zero clinical benefit for the addition of hormonal therapy. All you're doing is exposing patients to the toxicity of ADT with no cancer benefit. So this is what we need in terms of predictive tests, and this is where I think the data are strongest so far. So this is their report. Again, they give individual likelihood predictions of metastasis, which I tell folks to kind of ignore. This is the most valuable to me is this prediction about biomarkers. There's a new version of this that says something about active surveillance in the corner, which I would say they're not ready for yet in terms of what data have been actually published. There's a ton in the pipeline. We've got a big study in surveillance coming out relatively soon. This is definitely a space to watch. There's two other ones in the pipeline that are not available yet that are kind of coming down the pike rapidly, which are worth mentioning. One is Prostate. This is a collaboration out of Hopkins, where the main goal was predicting upgrading in active surveillance, and they were able to show in a richer multivariable context here, including MRI, by the way, that their prediction of grade group 2 or higher was associated with 70% higher likelihood of finding high-grade disease on confirmatory biopsy. So this one is one to watch. The other is Pathomic. This actually is at some point going to be launched as a combined test with Prolaris, which is why I'm mentioning it here. I'm still not exactly clear how the two are going to be incorporated. I think that's still being worked out. But that'll be the first of what eventually are going to be multiple efforts to combine genomic information with pathology AI information, which I think is going to be extremely exciting. So, Pathomic here, this is another imaging AI test, which was compared for predicting biochemical recurrence and metastasis after surgery, up against multiple true multivariable tests, and looked quite promising. Now, with all of these, every time you see one of these papers, you see some diagram like this, okay? And what this is some supposed representation of the model. But what they don't really explain is that nobody actually knows what's happening in these layers, okay? What is happening inside the black box of AI? And I think this is a really fascinating and important question. I don't know if any of you have ever seen one of these. This is Google Images, okay? How does Google know what a dog is and what a blueberry muffin is, okay? And this is exactly how these AIs work. How do you distinguish a Chihuahua from a blueberry muffin? Well, the AI, takes this image, breaks it down into an array of pixels, and then it starts to analyze the pixels, and it can draw lines and vectors, and eventually it identifies circles. And there's 120 layers or more of processing from the initial dot map to the call. And somewhere in Bangladesh or God knows where, some human is clicking dog pastry, dog pastry, dog pastry. So you have the outcome. And somewhere along the way at layer 60 or layer 43, it says circle, well, that's a blueberry, that's an eyeball. That's a whisker, that's a sprinkle. These layers of analysis kind of build up. And eventually it gets an outcome. And the model spins and spins until it's sort of optimized. But what is happening at layer 63, what's happening at layer 75, it doesn't know. You could ask it, how did you decide that this was a muffin? And it doesn't really know. You can, and the math is way beyond me, but it's basically doing, this complex matrix algebra multiplications at each of these layers. And there are ways to crack open layer 33 and sort of look at it and see what the computer is looking at. It's called these attention maps. So you can look visually and see, well, at layer 73, I think it was focusing on the eyeballs of the dog, but it can't really explain to you what it's doing, which is fascinating. And it's exactly, by the way ChatGPT works too. Instead of analyzing the dots, it's analyzing the letters and the words, but it's the same principle and the same math. And the Path AI models are basically doing the same thing. They're starting with tiles of histology and building up this understanding internally based on the same thing. Lines, circles, instead of an eyeball, it becomes a nucleus. It's measuring distance between nuclei. Who knows? We don't know what's necessarily happening at these layers. From the clinical test standpoint, it doesn't really matter. It just has to work, right? But over the long term, of course, we really want to know what's happening inside the black box. So, we have a grant at UCSF that's trying to crack this open. We have these tissue microarrays where we're looking at Artera along with other AI sort of analyses of what's going on at the histology level, and then doing spatial multiomics. So you can you can determine gene and protein expression at each cell in these TMAs at micro scale to really try to understand what's happening at layer 30 versus layer 70 all across the TMA. Final comments here, are we actually making better decisions based on these tests? That is actually a lot harder to establish, partly because, again, how the tests are presented, how the reports are formatted. Look, we already throw 17 numbers at patients, and a lot of them have poor numeracy. Do we really do a better job by adding a decipher of 62 on top of their Kappa and their nomogram score and their Shim score, and they've got their eyes glazed, and we don't even really know what to do with half the time. So, we have to be really careful about this. There was a cautionary tale from Adam Murphy, who ran an actual RCT in a low literacy population in the south side of Chicago a couple years ago, where they randomized patients to get with low-risk disease to get an oncotype score, yes or no. And the patients that got the score had more overtreatment, had lower likelihood of getting active surveillance than the patients that didn't get the score. Now, this is not because it's a bad test, and they didn't actually do the qualitative work, ask the patients sort of why, but I think a lot of it had to do with, at the time, the way the GPS report was formatted had all this stuff about, well, you were very low risk, now you're low risk with this NCCN thing, and people got freaked out because they were, the way the information was shown to them. So, to wrap all this up, this is obviously a rapidly moving space. It's incredibly exciting. These tools are becoming very valuable when they're used well and used selectively. I think it's really critical you're using the clinical information to the maximum before we start ordering anything adjunctive, and that means throw out the NCCN risk groups. All these genomic tests, they have to be shown to improve prognostic accuracy over a true multivariable model, and they do. They have all done this. They've all cleared these bars. Now, how exactly to use them, I think, is still very much an open question. And which patients benefit when we use them how? We do need more of these to clear the threshold for prediction, not just prognosis. And what's going to be really, really exciting is the convergence of genomics and path AI, and that's going to be a really awesome space to watch. So thank you. Here's our index test. We've got one more section.
All right, thanks, Matt. Home stretch. So back to our patient. They had a GPS score, it was high, 42. Went on to a radical prostatectomy, T3A disease, grade group 2, focal positive margin. So what's the next step? Do you give adjuvant radiation therapy based on a number of studies? Do you observe based on radicals and raves? Or do we perform one of these genomic tests? So genomic testing after treatment. I'm first going to talk about Decipher. And really, we've been very fortunate, I think, with all these tests. I'm going to highlight it right now, focusing on Prolaris and Decipher, that Prolaris was developed on biopsies, seems to apply to a post-prostatectomy specimen. Decipher was designed on a post-prostatectomy specimen and fortunately went back and can be applied to biopsies. So the first step is early radiation therapy, which means early salvage or adjuvant, or observation, or at biochemical recurrence, how intense are you going to be with your treatment? So these are the NCCN guidelines, just showing that Decipher and Artera can be used in this setting. And this is a Decipher report. It looks very similar to the biopsy report. You get a Decipher score, and again, as Matt said, it's a continuum and really should be treated as such. I think it's a good opportunity to sort of make your patients feel like you're better than what's out there, because I agree that these numbers, to me, are on the high side for what we see in our clinic. They're high for you guys too, I'm sure. And I would just say these are the numbers that the company gives, but I really think your numbers aren't this bleak. And this just shows how they compare in a continuum, sort of against their peers. So after surgery, radical prostatectomy, you'll do the test, decide whether or not they're going to get early radiation therapy or observe them. And if you're about to treat, then the question is, are they going to get radiation therapy alone or radiation therapy with ADT? So this is really the study that put Decipher on the map. It was the DEN study. If you have a low Decipher score, it doesn't matter if you get adjuvant/early radiation therapy with a PSA less than 0.2 or above the traditional threshold of 0.2, all the men did equally well. But if you have a high Decipher score, the men did much better if they received the radiation before 0.2. They did better with adjuvant or early salvage radiation therapy. As far as this was sort of a validation study, I would say, that came out of Hopkins, I believe, and it showed the same thing. Men with higher Decipher scores did worse and did better, though, when they received their radiation earlier. And for the low Decipher scores, it didn't really matter. What they did at Jefferson is they then sort of flipped the coin, and what they said is, you have a low Decipher score, we don't want you to do anything. Some of the men did nothing, some got radiation, and as you can see here to the left, men did equally well. But if you had a high Decipher score, they told you to get salvage treatment or adjuvant treatment. Some men listened, some men didn't. The men who listened did better than the men who didn't. So post-treatment, and when you're deciding on further treatment with radiation, is it ADT or no ADT? So really, I think RTOG 9601 was a landmark study that caused all of us to give a short course of androgen deprivation therapy with radiation therapy. Patients did better. And this is what Matt was alluding to during his talk, is when you look at that group, Decipher can help you pick out who truly benefited from the ADT addition. So yes, as a group, men benefited, but now we can really select out the men who truly benefit. If you have a high Decipher score or intermediate, so 0.45 or above, and you receive 6 months of ADT, those were the men who benefited. The other men didn't, and in fact, the overall survival for the low-risk Decipher scores who got ADT, their overall survival was worse. This is the balance trial. It's a PAM50 analysis of the cells, and if you have a luminal B positive situation on your Decipher, and this gets to the grid that we were talking about, if you're luminal B positive, you probably benefit from ADT plus apalutamide versus ADT alone. So again, it's another sub-analysis utilizing Decipher. I guess I'll get into the weeds a little bit. The only time that I'm finding this a teeny bit messy is I'm having a few patients now who have a low Decipher score, 0.43, and I'm going to give them salvage radiation. So that would say don't give them ADT, but then their lumen will be positive. Not quite sure what to do with those patients. Right now, I'm not giving them the ADT because I don't know that you can extrapolate that far, but I think that's a little confusing subgroup we're going to have to figure out. So the way that I use Decipher is if I have a patient with adverse features and I'm seeing them for their first postoperative visit, I do a Decipher right then. I tell them they don't have to, but the reason I like to do it then is that patient has had an MRI, biopsies, genomic testing, et cetera, et cetera. I'm going to order the Decipher now because they've hit their deductible, all right? And I tell them we're going to put that information in our back pocket, and I hope we never need it. If your PSA is 0 forever, I don't care what your Decipher is, you're fine. And if your PSA starts to creep up in the future and you have a high Decipher, I'm going to treat you earlier and a little bit more aggressively. And if you have a low Decipher, we're just going to observe things. So it's really information for a rainy day. If I have a non-nadir PSA or someone's coming in to see me with a biochemical recurrence, then I order Decipher. If they have a high Decipher, they'll get a short course of androgen deprivation therapy. I am looking at luminal B status now. Some of our medical oncologists are buying into adding apalutamide in that situation. In our group, as urologists, we don't give ARPIs. I know a lot of people do, and we could. But using that at that point to decide sort of on treatment intensity. Prolaris, same idea. This is a Prolaris score. It's a similar report to what Dr. Cooperberg showed us. And when you combine the CCP with the clinical variables, you come up with the cell cycle risk. This is just based on the cell cycle progression score alone. And you can see the higher your score, the more apt you are to have progression-free survival. This is looking at it the other way with the cell cycle risk. And again, the higher the number, Prolaris can predict metastasis and death. Another score is sort of similarly showing the same thing. And I found this, and I kind of didn't notice until Dr. Cooperberg was giving his talk, but it's the same number as the biopsy. It's this around, a CCR of around 2 seems to be the predictive number. And just like with the Decipher score, using these cutoffs of 0.45 and 0.60, it works for the biopsies and for the radical prostatectomies. But once your CCR gets above 2.2, that seems to be a break point for predicting metastasis-free survival after a prostatectomy. These were some validation studies, one from Hopkins, one from Swanson. And again, the sort of slopes of the curves are different, but again, very interesting that they sort of cross again around this 2.2 number. So that's the take-home message, I think, for Prolaris to use for your cutoff to decide who's apt to develop metastasis and who would probably benefit from adding androgen deprivation therapy to your salvage radiation therapy. But the difference is, with those studies they're, again, prognostic. These patients seem to do worse. They probably would benefit from ADT. I think the Decipher studies and the Artera studies are a little bit more predictive because they've gone back and looked at these studies, taking advantage of the RTOG studies and the data that's available there. But I do think these studies are going to become even more powerful. There's 2 Decipher studies coming out soon, NRG 09 and 10, where they randomize patients. Everybody got a Decipher, you're 0.45 or above, and you got randomized to either no ADT short course or short course if you had a high one, long-term ADT. And when those studies come out, those are truly predictive. So Artera, Matt already told us how this was developed, and it's the same thing, obviously, for a post-prostatectomy specimen. And if you have a post-prostatectomy Artera test that is positive for these biomarkers, those are the patients who benefited from adding ADT to the salvage radiation therapy. Sample report looks the same, really, as the biopsy report. And one thing that I think is very interesting when you look at these studies, and I think I put in one, but they were done on RTOG 9601 and also done on the SPORT trial. I can't remember the numbers for that one, but the SPORT trial was they took patients for salvage radiation, and they got bed alone radiation, bed plus a short course of ADT, or whole pelvic radiation with ADT. And they ran Decipher and Artera on both of those studies, and the 9601, right? They ran it on the same study. So now I'm going to go really back to the beginning and say that it bothers me that these tests aren't jiving when they're sort of supposed to be telling me the same thing, like who needs ADT, who doesn't. So this is a very small cohort that I did with 5 patients, all of whom had a PSA recurrence, and I ran an Artera on them, and I ran a Decipher on them. They all have bad Deciphers, right? All these men, based on Deciphers, should get a short course of ADT. 4 out of 5 are luminal B positive. They should get apalutamide added onto that. But 4 out of 5 of their Arteras say they shouldn't get ADT, right? So sort of leaving that out there is a big question of we're very early on in these things. It's kind of hard to know what to do with all of them, and I do think we're going to see as we compare these things a little bit of discordant information that we're going to sort of have to make sense of. And with that, I think we'll go back to the index case quickly. So this patient had a Decipher score of 0.76. His PSA was undetectable until 18 months, but then it started to rise. So that's a patient that I'm going to treat earlier and more aggressively. So he got salvage radiation therapy with ADT. And unfortunately, 2 years later, he had a PSA recurrence with a doubling time about 10 months. And we're not going to go into this today, but what next, right? If he didn't have germline testing, this guy did, he should. Do you do a needle biopsying of any metastasis? Do you do next generation sequencing? Are we doing circulating tumor DNA? Are we looking at ARV7? There's a lot of things in this space as well that I think more our medical oncology colleagues tackle than we do, but again, in the same sort of arena. And with that, I'd like to thank everyone for their attention, and we're happy to answer any questions.